Wisconsin is in Milwaukee. We're at Aurora Sinai Medical Center. We're talking about some of the healthcare financing issues. We're talking about Medicaid reimbursement rates, which is a major issue in Governor Walker's 2015-2017 budget. We're outside the Neonatal Intensive Care Unit, but we're going to start by interviewing Carolynn Glocka. She's president of Aurora Sinai Medical Center. Carolynn, thanks for talking to Wisconsin Eye.
You're very welcome. Thank
Give
you
us an overview of this major facility. It's now a medical center. It used to be called a hospital. So medical center means?
Medical center means a hospital environment, and this is an amazing hospital. We serve about 131,000 patients a year. 20 years ago, there were 8 downtown hospitals, so we're the final remaining hospital, so we serve a very diverse population.
You're the only remaining downtown hospital. Correct. So tell us about the unique needs of your patients because of the downtown location.
Because of our location, we serve a population that's 40% at the poverty level. 50% are unemployed. So the population that comes to us is very much in need of healthcare needs.
Well, then that must mean that MA, the reimbursement rates, and Medicare. Talk about the financing aspect, please, Carolynn.
At Aurora Sinai, our mix is a 70 to 75% Medicaid and non-reimbursed population of patients that come to us. So our shortfall from the Medicaid reimbursement, and Medicaid reimbursement only reimburses us 45 to 50% of every dollar that it takes us to take care of patients. So our Medicaid shortfall is quite large. In 2013, we had a Medicaid shortfall of $28 million.
Now, I want to understand that. That's $28 million in health care that you provided.
Correct.
That you were not reimbursed for.
Correct.
So who paid for that, Carolynn?
As a clinician, we provide the care no matter what. So we look to different avenues to pay for that care. Aurora Sinai contributed $4.4 million of charity care, and then another $5 million of community benefits which were unreimbursed. And then Aurora supplements us as well.
Well, let's talk about, we're a couple years into the Affordable Care Act. What's been the impact of ACA on your center?
Absolutely, and it's significant impact. I've seen since April, we've had an increase in the enrollment in Badger Care, which is the Medicaid, which tells me as a hospital administrator that our shortfall will grow even larger from here. I have also seen from the clinical side, I'm a nurse by education, so from a clinical side, the patients who are now reimbursed, who are now insured under Badger Care, are coming to us much sicker. So they come to us and their diabetes is out of control, their asthma is out of control. So we not only have to take care of that acute problem, but then we have to make sure that when we discharge them back into the community, we're providing them with the resources and education so they don't keep using the emergency room as a revolving door. So we make sure that they have an appointment with a primary care physician, and we make sure that they keep those appointments. In addition, one extraordinary point that we've seen is the people coming to us have much more behavioral health needs. So they're coming to us with diabetes, but they have many other needs. They've lost their home or they've lost their job. So those behavioral health needs are just complexing the complexity of the care that we provide.
As a healthcare professional, then, is it a good thing that you're seeing more Badger Care patients because more people who might not have been getting health care is now getting it, Carolynn?
Absolutely, absolutely. We want them to come. We want them to come to us so we can stabilize their care and that we can get them a safe discharge and that we can hook them up with that continuum care so then they can take ownership of their health and maybe they can live a better life from there on.
Medicaid reimbursement rates are set by the state government, correct?
Correct.
Well, then how important is the decisions that the governor and lawmakers will make in terms of MA reimbursement rates for the next budget, the 2015-2017 budget?
The DISH payment, the disproportionate share payment that Sinai receives, is $2.5 million. And although that doesn't cover our deficits, it really gives us the dollars that we can put back into supplying the community with the resources and education that they need to take care of those patients.
So if you were testifying, or if the governor called you up and said, make me a recommendation for the MA budget and the next budget cycle, your short advice would be?
please reinstate that. We need it. I mean, our patients need it. Our communities really need those dollars. It really helps.
What's the downside? What are you most worried about in terms of 3 or 5 years out if the DISH program is not increased, if our MA rates are not increased?
We'll have to look at the services that we provide and maybe narrow those services, which would only affect our patients, and then they would be in that circle of illness rather than in the circle of wellness.
Explain the role of the, let me get this right, neonatal intensive care unit. Are these your sickest patients, or are they your costliest patients?
They are definitely our most costly patients. When adult patients come to the hospital, they're here for a very short period of time. So we fix that incident of care, and then we discharge them into the community. Our NICU babies are teeny babies, so their extended length of stay is very costly, and they need resources. So absolutely our most costly group of patients and our most needy.
Good. Can we go talk about those patients?
Absolutely, and I will ask...
Shall we take 100 adult steps and 500 baby steps, did say, into the unit?
You try the baby steps, and I'll do the... because I've done this, so I'll do the adult steps.
Okay. Thank you very much, Carol.
You're welcome.
Wisconsin Eye is in the neonatal intensive care unit at Aurora Sinai Medical Center. Thanks again to Carolynn Glocka for joining us, and now Shelly Reid, director of the NICU unit. So babies are saved here, but that's too simplistic. Tell us about the unit, please.
We have a 32-bed neonatal intensive care unit. We take care of babies from the brink of viability, which is around 23 weeks gestation of a 40-week full term, what we consider a full-term pregnancy. And then all the way to babies that are born ill for whatever reason, that may be term, but we would save them here.
What percent of births involve babies that have to be treated here at the NICU?
We usually see about 10% of our births here at Aurora Sinai come into the NICU here. So last year we had about 400 admissions here to the NICU, and of those 400, about 100 of those were what we call micropreemies. And micropreemies are the much smaller babies, about 3.3 pounds, and those are the ones that are critically ill and need a lot of support from the neonatal intensive care unit and the team.
But I'm so intrigued. A member of your staff said that you were able to save a baby born at 12 ounces?
Yes, we have, on record, we have the smallest infant born in the state of Wisconsin. And she was born actually almost to the day, January 11th, 2005, so 10 years ago.
Now talk about the intensive level of staffing here. It's an intensive unit, but what does that mean in terms of staffing?
Intensive care staffing is, the ratios mean that we have more nurses to the patients. So right now we're staffing usually 2 to 1 or 3 to 1. And we have all nurse caregivers at the bedside. We also have a team approach, so we have respiratory therapists that help us. Of course, our wonderful neonatal intensive care physicians, as well as dietitians and pharmacists that help on the team.
And Carolyn was saying earlier that these patients, these babies, are some of those that stay the longest at the facility. Average length of stay?
Average length of stay for me in this department is 21 days.
21 days.
But for the micropreemies that I was describing, those could be 3 to 4 months.
And what are the most common conditions that land a newborn in this unit?
Respiratory distress, and sometimes hypoglycemia or having a low blood sugar. Sometimes babies are just, they're not doing well, they need oxygen or things like that. But for the most part with prematurity, what we deal with is the respiratory distress. And then from there, making sure that we provide an environment for them in which to grow. So that's a big thing in a NICU, making sure, because we can't replicate a womb, but we have to do the very best we can with lighting, sound. We really control the noise. We control lighting and the environment. So I'll talk a little bit about how important an environment is for a neonate when we discuss the giraffe beds.
Okay, great. But every one of these babies is surrounded by loved ones who want them to make it. How do you balance the need for medical care with the human touch from a parent, spouse, grandmother, etc.?
And neonatal nurses do not just take care of the baby, they're taking care of the whole family. And our goal is to truly have a family that comes together as one. Our goal is to reunite these babies with their families and have a great experience at home. So we have 24-hour visitation. We welcome families here. We encourage them to participate in cares. We do it with them. We set goals with families on a daily basis with the nursing staff. So it's really an integral part. What we do see in our community from a socioeconomic standpoint with our families is an immense need for services. So our nursing staff here has realized that need, as has myself and the administrative team, and there's many programs that we've tried to put into place through philanthropy. And because of the shortfall that we do realize, currently here in my unit, we are reimbursed about 50 cents on the dollar that we spend to care for these babies. So it is a huge loss for us, but it is a passion, and we're serving our community. So for us, the staff has actually put together a car seat program that many of them donate to. So our goal, every baby that leaves our NICU goes home in a car seat. We also have the swaddle program to demonstrate safe sleep practices for our families. So there's many programs that are important for us to make sure we have a whole family at the end.
Well, babies are saved here. Those are pretty expensive babies, as Carolyn was alluding to. So can we have an example of maybe one?
We had a case, it was a $400,000 case. It was a very sick baby who came to us and was with us for close to 5 months. And when Medicaid reimbursed us, we received $40,000. So that was 10 cents on the dollar. And that was...
It cost this facility $400,000 and your reimbursement was $40,000.
Correct.
Do you have any right to appeal that, Carolyn?
We go through all our appeal process, but the reimbursement is the reimbursement. And sometimes, we provide the best care, and then we make do with what we get, and we pool our resources together and make sure that they have the support.
What are some of the factors that lead to babies having to be treated here? And maybe a follow-up question is, what are the most common types of conditions that are treated here, please?
For us in this department, our number one reason for admission is prematurity, and there can be many reasons for prematurity. In our community, our women are at more risk because they have high blood pressure. Obesity is rampant. We have a lot of depression and anxiety and stress. Studies have shown that African American women are just at higher risk for stress in general, and that causes prematurity. So that's our largest population that we bring in. Other than that, it could be rule-out sepsis, it could be a low blood sugar. Respiratory distress is where the baby's having a hard time breathing on his own for a little bit, but those are our main areas.
Obviously, this is a intensive care unit. So can we talk in terms of ratios? What's the staffing ratio, nurse or other healthcare professional per baby?
To provide excellent care and outcomes for these babies, we really need a multi-interdisciplinary approach, which means we have nurses, physicians, dietitians, respiratory therapists, but the actual, to answer your question, nurse to patient ratio is about 2 to 1 or 3 to 1. So every nurse has 2 or 3 babies that they're caring for with the rest of the team.
And the lights are never off in this unit, are they? 24/7?
24/7, correct.
24/7.
This looks state-of-the-art, and I'm going to say all I know that this saves babies, but go ahead and explain what this is, please, Shelly and Carolyn.
Absolutely. So for us, it's really important to keep up with technology. Technology changes so that we can save younger and younger babies, or babies that we may not have saved 30 years ago. So one of them is this piece of equipment. This is the Giraffe Omni Bed. What makes it so special and different from our previous beds is that it's all in one. So we would put the baby in this bed right at birth, and would not have to move the baby for 2 weeks.
Would your smallest and sickest babies go in here, Shelly? Excuse me for interrupting.
Absolutely would go in here, and what the importance of that is, a very small baby born prematurely is at high risk for what we call an intracranial bleed. And we want to make sure that we have the best possible outcomes for these babies. And so if we can get them into an environment, as I was explaining earlier, and not disturb them, keep them as quiet as possible, the risk of that intracranial bleeding or bleeding into the brain is dramatically reduced.
So they will go from birth into here.
They'll go directly in the delivery room.
Those that are most at risk, correct?
The highest risk babies, correct. For us, like I said, was 100 babies last year.
Is that up dramatically over the years?
It's not up. I would say it's not going down, but it's not up.
Before we see how it works, let's talk about, Carolyn, how much do these units cost, or how much do these cost?
$38,000.
$35,000 or $38,000.
Correct.
And your facility has how many?
9. We have 9.
We have 9.
Of a 32-bed unit. Our goal is to have all beds to be on this bed, and they're constantly in use. So when one baby, it's been 2 weeks and we have to move the baby into another bed, that giraffe will go immediately be cleaned and be put back into service.
With MA reimbursement rates as low as we've been talking about and price tags that high, how does this facility afford to buy 9 and eventually more than 30, Carolyn?
Amazing fundraising, and we reach out to our community. We reach out to our community partners and look to them for assistance. Absolutely, and they have been very, very generous.
Do they have to buy? Do you ask them to buy the entire 35 or 38?
Oh, we'll take anywhere from $10 up to $35,000, because you know what, $10 amounts to $100 to $1,000, and eventually you get to that. So we have funds that we build on all the time. Very generous. Very generous.
Did I hear units like this were once shown at a Bucks game to try to build support? Really?
Yes,
rolled out in a halftime at a Bucks game?
We did that. And it was very fun. I don't know if you remember Dan Gazarich. He was a partner with us during his time here in Milwaukee on the Bucks, and his lovely wife, and they did a fantastic job for us and helped raise enough money to purchase a whole bed.
Okay, well, you're going to show us how it works?
Absolutely.
Shelly?
So what really for us as clinicians, because what we're worried about is access to the baby as well as that environment for the baby. So once the baby's in here, if there's an emergency, we all need to get in. And as I explained before, it's going to be the physician or respiratory therapist and a nurse, or sometimes 2 nurses. So if you imagine a little baby being in here, we can have quick access at a touch of a button. It raises this, and then at the same time, up here opens so heat can come directly down onto the baby so that we keep the baby warm. If it's an emergency, we can go ahead and take down all the sides. Steve, if you'd like to take little clips right here, yep, and then it pulls down, and the whole thing comes down very quickly, and you have all the way around access to the baby.
Okay, so, and there's a ventilator unit in here? And
the vent is separate.
The vent is separate?
We do have air and oxygen attached. The main piece for this is the humidity and the heat, and then having access for emergencies, having the direct heat when we have to open. Those would be the main pieces.
And excuse my ignorance, but what's this?
This will actually hold the, when there is a ventilator, this holds the breathing tube for the infant.
And is there an average time, only the sickest babies go in here, tragically, right? Mm-hmm. But an average time they might spend in here?
If we had 31 beds, every baby would be in it.
That's our goal, right, because it is the best environment, so we want to make sure that all of our babies have that opportunity.
And if a mother wants to come in and touch the baby, mm-hmm, that human contact, she can come right in, mm-hmm, here and put the sides down? Absolutely, and what we do with the moms, once the baby is stable enough, is we will allow for the opening so they can feel. And I've actually had moms sitting, because another nice feature is that this raises and lowers, so the whole bed itself can come up. So if you're standing and working with the baby, you're not bending over. And then for the parents, that it actually goes all the way to sitting level. So if a mom is sitting or a dad is sitting in a chair, then they can be very comfortable. And I've seen moms sitting in the chair and hugging their baby right in the bed, and it's just beautiful. Now, we talked about the record baby that you saved that was 12 ounces, which the plaque from the governor says was really 11.7. But that baby's birth occurred prior to these Giraffe units? Correct. So how long have these units been around? We've had these units since 2006 that we've been working on this project to bring them in. With medical technology reinventing itself, it's kind of like, software. What's going to be the next generation and the next need in this unit? There will always be a need for the next generation of technology, always, and we need to make sure that we're moving with that technology in order to provide that best care. That's what Sinai is about, is that compassionate care, and part of that means we need the technology to support the staffing for that. Another area that we did not
touch on was our volunteers. Sometimes those families just can't be here, so we have incredible volunteers that also can stand by these babies when the parents need to take a little break. So it's amazing. So these babies are never alone.
They're never alone.
Never alone.
But a volunteer, aren't you worried about the volunteer having a cold or something and further?
Everybody's screened before they come in, even families, because we really are concerned about bringing any illness into the unit. So all families are screened, and siblings, once they come in, we screen them at every visit.
So this is an example of how your sickest newborns are treated. And they're in here for a matter of weeks. They have access to medical care, and they can also be hugged by their parents.
Absolutely, best care.
Is there an average size weight baby that goes in here? Because look at this diaper and look at this head to keep the head warm. Are there some averages here?
Sure. The smallest would be around 12 ounces, and then we have had babies born here very large, up to 14 pounds. For us, an average...
A 14-pound bruiser can fit in here?
Mm-hmm.
Okay.
And then an average, I would say, would be about 1.5 pounds for an infant brought into for prematurity that we would utilize this bed for.
And to put that in perspective for you, 12 ounces is the size of a Coke. A can of Coke, that you hold in one hand.
And is there an average number of days or weeks that a baby would stay in this, Shelly?
Depending on gestational age, so the more premature that they are, usually the longer that they'll stay. We always tell parents that think about your due date as a goal date, plus or minus. We do very well here, and we usually, and that we don't make promises to the families, are able to get the babies home a week or two prior to their due date.
And once a baby can be released from this, where does she and he go then?
We also have traditional isolettes that don't open and have all the bells and whistles, but they're sufficient to care for the babies, absolutely. But as technology changes, we want to keep up with what is the best practice and make sure we have the best outcomes.
So in summary, Carolyn, the facility has 9 of these. You'd like to have how many?
32.
32. So there's still a need, so you're probably out there still fundraising?
We are fundraising. We are telling our story out in the community, and the community is listening.
Are you showing him props like this?
It's a great idea.
Can we talk about the changing needs of mothers who are about to give birth and the conditions that you're seeing in their babies?
For me at this department, and I know statewide, 2 major changes. One is we're seeing a lot more infants born drug addicted, and that what we're ascertaining that to, contributing that to, is that we have a lot more medical homes for pain medical homes, and methadone is a big component of that. And so we have women are on that as they're trying to get off of their oxycodone or pain management drugs from maybe they were in a car accident or something like that. So once a woman comes into the hospital and she's pregnant, her other issues don't go away, and that also includes behavioral health issues. So we do work with our families and our parents and our mothers specifically here on behavioral health issues, and all of that care is not reimbursed. That's not billable, that's what we do here, but it puts a huge strain on the staffing.
This is a 32-bed unit on any given time. Roughly how many would have that issue?
We're a 32-bed unit, and at any given time, about 1/4 of the babies here are drug-addicted babies going through withdrawal that we're supporting through that.
If a baby is born drug-addicted, what unique medical issues does it pose in terms of treating that baby, Shelly?
Babies born drug addicted are at risk for having seizures, for having long-term learning deficits. Sometimes they don't breathe well on their own, so we have to support them through that initial phase, and then we have to support them while we wean them off of whatever medication to get them home, and that can take time.
You're seeing a lot more babies born with that condition.
For our department here, at any given time, we would have approximately 5 infants in here.
But that's not just true in the city of Milwaukee. That's also true statewide?
Statewide, nationwide, and it's everywhere. Even up into the UP, there's a huge problem. Upper Wisconsin and Green Bay and even west. So it's truly a epidemic, and it's truly a statewide epidemic. And I wouldn't want anybody to think it's just the inner city, because it's not.
Okay. Carolyn, in summary, let's talk about the major decisions that will be part of the next state budget. Governor Walker is going to recommend it on February 3rd, then lawmakers will vote on it between now and June. But if you were testifying before the Legislature's Joint Finance Committee, what do they need to understand about the issues and babies like this?
And, you know, I appreciate being able to share that. I think we demonstrated today just some examples of the problems that we face and the conditions that are out in our communities. This is, you know, we have a lot of problems focused at Aurora Sinai because we're that only downtown hospital. But the problems that we face and that we need assistance and supplements from are Milwaukee, the state of Wisconsin, and across the country. We have huge needs because our community has huge needs, and we need to bring those together.
Well, thanks so much for shedding some light on these issues, financial, and congratulations on all the success stories that you have in this unit.
Thank you.
Thank you.